Professor Grube from Germany, what is important in structural interventions today? You are the pioneer in this field.
First of all, everything is important in structural heart disease, but I think we have passed the aortic valve and now we're moving into the mitral valve and the tricuspid valve. We had some very interesting sessions this morning, how we developed the trials from the very extremely sick patient to the low risk patient. So I think the aortic space with some gaps obviously is still open, but then we have to move on now, and I think now we are in the mitral and the tricuspid space.
And Patrizia Presbitero, what so far did you get in the morning and afternoon session out of this meeting? Things that we have to take home.
Take home, first of all, that we are able now to treat even very difficult cases. I'm talking about the degeneration of the valve, so to put the valve in valve, also to intervene on mitral and tricuspid valve. We are now able to face patients very sick. We can offer much more than what we offered before. And secondly, we have also many more tools to make our intervention with less morbidity and mortality. I think you spoke also very well about the tip and tricks and how to face the complication now. So we learned a lot, I think. And now I wanted to ask you, you think it's really over? We are able now to prevent all the problems that we can face in performing percutaneous intervention in TAVI and in aortic and mitral and tricuspid valves?
But to answer your question, I want to continue on what you said about the safety and the complication and the ability to deal in a minimal invasive way even in front of complications. Few years ago we had problems. Now we see that these structural interventions are becoming very safe procedures, even safer than some coronary interventions. So I totally agree with you, and I even would come to the point that even if we don't want to give up on the heart team, on the evaluation by the surgeon about the case, we may, and I don't think we need to go too far in time, we may believe that this intervention will be done without surgical backup. Because I believe, at least with some appropriate case selection, we may not need a surgical backup to do routine structural interventions.
Yeah, I think we have to differentiate. I think the aortic space is well covered about, and you can argue about the surgical backup. I think on the mitral and tricuspid, we are far away from having any complete solution yet, so that will take some time. And let us be honest, what we tried to do initially, we thought mitral is another TAVI, and that is certainly not the case. We basically started out in 2004-05, and now we have 2019. In 15 years, we have established a new treatment option for these very sick patients. We are not there, by far not there, in the mitral and tricuspid space. So that takes a little while yet.
Okay, I think the message is that mitral is not the aortic. No. Aortic is a disease of the valve, easy to be solved. Mitral, I would like to say that it's like anemia. It's a sign of multiple disease. Yes,
but don't you think that nowadays we, with the mitral clip, we can offer to patients, for example, a rupture of papillary muscle in acute myocardial infarction, who before were dead? We can offer still a solution. So we contribute not only to bring patient from surgery to us, but also to give something more in the patient in which surgeon couldn't do nothing.
Yeah, well, it's that's why the COAPT trial is such an important trial, because for the first time a device can be, used in heart failure patients, which has not been the case before. But as I said also before, the COAPT is a blessing and a curse, because it is very safe, but we also know it's not a complete solution of a very complex problem. So we have to see what the future will tell.
Okay, thank you very much.